All right. So, and was there any questions from the first section we covered last week? I'm going to try to finish this up. We'll see what we can get through on the next section, and then if we have time for review next week, that'll be good. And we can kind of have any wrap up thoughts and kind of finishing statements then. So. Now we talked about hormone replacement therapy, and now we're kind of moving into the oral contraceptives. And what's kind of the big difference in the kind of the paradigms here as far as the amount of estrogen that we're giving these patients when you're kind of comparing HRT versus oral contraceptives? Yeah, HRT is just going to be a replacement. We're just trying to kind of get patients back to whatever their kind of normal baseline would have been when they were producing their own estrogen. Here, we're trying to shut the whole system down, and how do we do that? So we give them a lot of estrogen, we give them progestin. What does that do for us? The negative feedback loop, right? So what does that decrease the production of? FSH and LH, good. And then what does that do? Can't ovulate, right? So again, you're not going to be releasing that nice egg. So and there's some other changes that happen as well. You're going to see where like kind of the environment makes it kind of inhospitable to the sperm to meet up with the egg at a point. So there's several ways we can do this. We'll talk about mainly oral contraceptives because that's kind of what the most common thing you're going to run into is. But we'll talk about some alternative means as well. Some of the drawbacks and some of the things to kind of consider and things good education points for your patient. Because again, you want them to make sure that people are taking these appropriately. Because this can have pretty deleterious consequences if someone does not take this appropriately, and because again, what's the big side effect you worry about if you use this inappropriately? Pregnancy, right? And again, no one wants to get surprised by pregnancy. Not usually, right? So again, some people maybe, but if they're taking this stuff, typically, and again, there are other uses for oral contraceptives. What can other uses be here? Yep, they can have to regulate their periods, right? So they have really bad like dysmenorrhea, or they're having like really bad, bleeding. These are things where these can kind of help to regulate that a little bit. And what's kind of cool, and what's something I never even considered when I was like in pharmacy school, is that you can like reschedule the entire menstrual cycle. You can like do all kinds of things like, hey, if you want to have 4 periods a year, guess what? We got drugs for that, right? And there's a way we can modify that by giving these different hormones. I thought that was like black magic to me. I was just like, what? Like, it's like sacrifice an animal or something to get this to happen? No, you can do it with hormones. And so there are other uses for these than just birth control, but however, that's one of the main uses we'll see here. So we'll talk about some methods we can do that. We'll talk about honeymooning and things like that. But anyway, so we're using a combination of estrogen and progestin. We're trying to kind of mimic what the natural body would be producing to some degree. And you can have different kind of treatment modalities here based on the different doses and how you kind of modify the doses throughout the month. Because again, they're typically receiving active drug for how long for most like oral contraceptive packs? Yeah, usually for 21 days they're getting actual drug, and then for that last week they're getting what? Yeah, usually placebo, right? It may have some iron in it, but for the most part, these products will have placebo for that last week. And so there's different means that we can modify the dose. We can have kind of monophasic sort of dosage forms where basically the combination of estrogen and progestin, the doses really don't change at all throughout the month. There can be biphasic, which you're going to find there's one point in the month where the dose will change. So maybe you get 7 or 14 days of maybe a progestin at one dose and then it changes. And that's trying to get a little bit closer to what the natural cycle would kind of be as far as levels of estrogen and progestin go. And there's like a triphasic, which gets even more specific, and there's kind of 2 points where either one or both components can change twice throughout that cycle there, right? So again, you'll find that some are going to be better for one type of patient versus another. Everyone reacts a little bit differently to these different hormones. So it just depends on your patient, kind of what they do best with. Some people like to limit the total amount of hormone that they're getting per month, and so you can kind of do that by using some of these triphasic products and things where they'll use maybe lesser amounts of hormone in the early parts of the month, and they'll kind of gently ramp up. And again, go back to that chart and kind of see some of the different ways that they can modify that. The other way you could do it is just by continuous progestin-only therapy. Does anyone know any drawbacks associated with that? You have to be very specific on how you take it because there's higher risk for failure, right? So again, these drugs are very, very good when you use it with perfect use, right? It's not 100%, right? Because nothing you can say is absolutely 100% in life, except maybe death and taxes, as they say. However, you're going to find there's a little bit higher margin for error when you're using progestin. They want you to take it the same way every single day. Because that error is a little bit larger, you want to make sure you're not kind of having any kind of variance with that. So we'll talk about more of those issues as well. There's some other issues with progestin-only therapy as well. We'll talk about things like delayed return to ovulation, which can be a problem for patients who are trying to get pregnant. There can be some issues with bleeding. We'll mention those as we go on. So again, by activating that negative feedback loop, by giving kind of supratherapeutic doses of estrogen, progestin is going to feed back and shut down that hypothalamic pituitary axis there. We're going to have less GnRH being released. We're going to have less LH and FSH being released, and that will prevent ovulation from occurring in the first place, right? We're also going to see some things where you have like changes in cervical mucus. You're going to have changes in, say, the motility and secretion of the uterine tubes. All these things are making the environment very inhospitable for that meeting of the egg and sperm. The implantation really can't occur at that point, right? You're going to find in some cases like things like progestin-only therapies may not actually inhibit ovulation, but they are changing that environment to such a point where that meeting and that implantation is not going to happen. So, for instance, when we're talking about IUDs, what does IUD stand for? Intrauterine device. Those actually don't inhibit ovulation because they're having very localized effect right there in the uterus. They're only changing the environment there. They're not actually feeding back and affecting the pituitary as much as you would see with like a systemic therapy, and that can be beneficial in some cases. But you don't absolutely have to inhibit ovulation. That is an additional benefit of using something more systemic, right? So something that may get a little bit more effective in those cases. So again, looking at the physiologic effects here, you're going to find that typically you're going to have depressed ovarian function. Typically, they tend to atrophy to some degree. It's very similar to if you were to give testosterone to a male, what happens to the testicles? They shrink, right? Because again, they're going to atrophy because they don't need to produce as much testosterone. The ovaries don't need to be really producing estrogen as much. They're going to shrink a little bit there. Typically, most patients will return to normal menstrual patterns when they come off these medications. It may take a little bit of time, and you're going to find that progestin-only therapy typically takes longer in some cases, and we'll kind of talk about that a little bit later. But, about 75% of women should return to ovulation within that first cycle, 97% by the third. However, some people will be anovulatory for several months to years potentially. Just you can't really predict who's going to have that issue there. But and then typically with like the uterus, you're going to find like there's some hypertrophy here. May have thicker, less copious mucus, and again that makes it more difficult for the sperm and the egg to actually get together and implant. So other things you can see. Why do you think a breast enlargement would occur here? Yeah, because we're giving bigger doses of estrogen. Again, that's an additional concern you have, especially for patients who have high history or high risk history of breast cancer, especially estrogen-dependent breast cancer. That can be an issue there. You can also find it suppressing lactation, which can be problematic if you have someone who's still breastfeeding. Absolutely. So again, if you have like a mom who is, oftentimes moms will go on birth control after they give birth in order to make sure they don't get pregnant again, like some people. You're going to find that can be problematic if they're taking systemic hormones because that can actually depress their milk production. That can be a problem for the baby, right? You may have to switch them over to additional formula or something. The other big thing you're going to find, this is going to be one of the main side effects we're going to be worried about from an emergency sort of side effect thing, is going to be these hematologic consequences. And a lot of this has to do with those estrogens getting processed through the liver and stimulating production of clotting factors, right? So we mentioned clots being a potential risk here with like hormone replacement therapy. It's higher here because, again, our estrogen doses are typically bigger than we would see in hormone replacement therapy. Absolutely. So again, there's a lot of thromboembolic concerns due to the fact that we have more clotting factors, and antithrombin 3 is going to have a decrease in activity. Remember what drug helped antithrombin 3 to work faster? Use it for anticoagulation for like a PE or a DVT. Wasn't warfarin. Warfarin inhibits vitamin K, inhibits clotting factor production, right? Remember heparin and like enoxaparin? Remember those drugs? Those are good anticoagulants. Those actually help antithrombin 3 to work faster if you go back and review those lectures. Anywho, other things you can see potentially, you can see some hyperpigmentation here. Typically, areas that are more exposed to ultraviolet light, you can have a little bit darkening of the skin there. Some of this may be somewhat reversible, some of it may not be. It just depends on the cases there. And also, you're going to find that in some cases, the progestins, depending on which one you use, can have some androgen receptor activity, which can lead to some of the side effects that are a little bit more worrisome or problematic for your patients from a quality of life standpoint. You're going to find that it can do things like produce sebum production that can actually worsen acne. For some patients actually do better when they are on oral contraceptives, actually improves their acne. However, some people are going to get worse. And again, everyone acts a little bit differently. A lot of it goes back to the progestin that we're going to be using. And I'll show you a chart here in a little bit later that kind of gives you a good comparison between the bunch. Sorry, clinical use, the main thing is going to be for contraception, try to prevent pregnancy from occurring here. And if you take it according to directions, the risk is very small of having a pregnancy, and this is without using any other form of protection at all. Say combination agent, so estrogen plus progestin, maybe 5 to 12 pregnancies per 100 women years at risk. That's with like typical use. That's what, and again, that sounds like, how do you actually, what is 100 woman years? So if you followed 100 women for 1 year, or maybe one woman for 100 years, again, that would be kind of unrealistic to do so. But anyway, basically it's a combination of that. Basically you're monitoring that period of time with normal typical use, with people just being people and maybe missing some doses and things like that. Maybe 5 to 12 pregnancies during that whole 100 years, right? Not too bad, right? 100-year span, you only have 5 to 12 unintended pregnancies. That's pretty good, right? Most people are not going to be using it absolutely perfect, but if you did have perfect use, the estimate would be about 0.5 to 1 pregnancies, right? I don't know how you have half a pregnancy, but that's kind of what they estimate, right? Well, they just pop out like the top half of the kid or something, but you wouldn't want that. You have to be careful. Like, consider, what other medications might be on board. You can find that if you have things that induce hepatic enzymes, things like phenytoin, that can actually work to decrease the activity of estrogen, or decrease the levels, and that can increase your risk for having an issue there. That's also another reason why we worry about antibiotics. It's a little bit more of a theoretical concern, but we mentioned that estrogens, they get processed through the liver, they get sent out through the biliary tract, and then gut bacteria can metabolize that and then allow them to be reabsorbed. Okay, that's that enterohepatic recirculation. If you interrupt that, you can decrease your levels of estrogen, and that can potentially lead you to have an ovulatory phase and potentially have a pregnancy. So that's why theoretically we say, hey, if you're going to be on antibiotics, we would recommend you being on some sort of backup contraception. Which antibiotics specifically, I like to be safe and just say, hey, just in case you're on antibiotics, I really don't want someone to come back and be like, well, you didn't warn me about that, and now I'm pregnant. That's not something I want on my conscience, right? So again, I just kind of mention it to everyone, but typically things that will have a bigger effect on the gut bacteria, so things that affect like anaerobes like Clinda, metronidazole, those would be ones I'd be a little bit more concerned with, but just as a general rule of thumb, I just kind of mention it. You're never in it's never bad to recommend more backup protection than not, right? So. Okay, some other things you can find, some clinical uses here, endometriosis. So patients who are having, pain associated with this, and estrogens alone may be good enough to kind of help with this, but what's kind of the problem with using estrogens alone for these kind of patients? Yeah, they still have an intact uterus. They still need some progestin in order to help eliminate that tissue when you don't really need it, that sloughing aspect of it, because again, you don't want to have that kind of unopposed estrogen effect there because you worry about endometrial cancer risk. Now, typically, again, to limit side effects, we like to use the lowest dose of estrogen possible while still kind of maintaining kind of the clinical effect we're looking for there. So that's one use. Now, adverse effects. Certainly, there's some mild ones, and there's some kind of more worrisome ones that we want to be aware of, and things we want to educate patients that, hey, this is something where you should stop therapy totally and go to the hospital and things like that. But mild things you're going to find. So nausea, some mastalgia, which makes sense based on the estrogen effects on the breast there. You can have some breakthrough bleeding. And where do you think the edema comes from? Steroid propagation. So yeah, so usually going to be from the progestin having some of that mineralic corticoid effects, right? It's going to act a little bit like aldosterone. It's going to cause some fluid retention to occur there, right? So again, that kind of makes sense based on normal menstrual patterns. Like typically women tend to complain of some edema that occurs, and that's usually due to that aldosterone sort of effect holding on to more fluids, right? Now, if you're having this could be related back to too much estrogen effect here, and so you can do things like maybe lower the doses, right? So lower the amount of estrogen you're using throughout the month, or potentially using progestins with, say, more androgenic effects. This can tend to help out with that to some degree. And we'll talk about different progestins in a minute here. Now, some patients are going to have headache associated with this, and some patients, they may actually have worsened migraines due to this. And we mentioned back when we talk about migraines, what's a preventative potential therapy for females? The oral contraceptives, right? So it's hard to predict who's going to do better or not, but it's one of those things where, hey, they're complaining of worsened migraines, like, hey, if you start any new medications and say, hey, started this new oral contraceptive, that could be a clue to say, well, maybe you're not a good candidate for that, or maybe we need to switch to a different product, right? So certainly I would discontinue therapy if a migraine coincides like directly with therapy, and may need to use a different product altogether at that point. And then one of the other things, you may find that withdrawal bleeding may fail to occur, especially when you kind of first start out on some of these products here, and that can be problematic, right? So if you go into the placebo pills, you would expect what to happen? You expect bleeding to occur, like you expect normal menses to happen. But if that doesn't occur, what would you naturally suspect? Perhaps I'm pregnant, right? So perhaps I should go get a pregnancy test. Again, it's one of those things where after the first month, like we don't recommend jumping out right directly to getting a pregnancy test. But it's one of those things where you need to educate them, hey, this may not occur the first couple of times. Just know that it may take some time for your body to kind of get used to this new kind of normal for them, because they're not used to having all these extra hormones around it in a lot of cases. So if it's problematic, though, you can try switching over to other products, and we'll look at some of those in a minute here. So some other moderate things you can see, breakthrough bleeding tends to be more pronounced if you have progestin-only products. That happens there. And then you're going to find this also more likely to occur in very low-dose products. So just be warning, hey, like we can try to limit how much hormone you're going to be exposed to. However, you may see more side effects associated with that from a bleeding standpoint. And what they can try to do is also use like a biphasic or triphasic product where basically they're going to try to shift around where you're using the hormones. So the total monthly amount doesn't really change at all. You're just kind of top loading it in one side of the month or the other in order to make sure that it's a little bit more close to what the natural cycle would be. And that tends to help out with some patients. That's one thing you can do. Weight gain tends to be more pronounced with more androgen-based progestins. More things are going to have more mineralocorticoid effects. That's one thing to look at. You can help this with things like dieting, or you could use a product maybe has less progestin effect or less androgenic sort of hormones. So that'd be one thing you can do with the weight gain. Okay, some other things we mentioned, the darkening that can occur here. This is especially in dark-skinned women tend to have a little bit more darkening that can happen here. Some people will develop this with time, so the longer you're on it, the more likely you are to have this occur in some cases. And typically it's reversible, but it can be kind of slow to do that. It tends to be a little bit worse in patients who are vitamin B deficient, so I would recommend probably taking a multivitamin anyway. And again, even if you're not trying to get pregnant, I still recommend taking prenatal vitamins because again, it has what in it that's super important in case you get pregnant? Folic acid, right? That prevents what? Yeah, neural tube defects, no microcephaly or anencephaly and things like that. We want to prevent that. So again, don't have to be trying to get pregnant if you need prenatals. And then the acne thing, so again, you can potentially see more androgen-like progestins kind of worsening acne. And so by using large dose estrogen, that may actually improve in some cases. So again, just depends on your patient, see what's kind of best for them. That's again, you can kind of imagine why there's like a million different products that are out there, because again, you kind of have to go and try a few different ones before you find the one that's like really good for your patient specifically. Okay, some other things. Hirsutism can occur, but that's mainly going to be due to some androgenic progestins. So if you can switch one that's less androgenic, that's going to be good. You can see some urethral dilation. It's kind of similar to what occurs in pregnancy, and that can actually lead to some bacteriuria. So if you have someone who's maybe more prone to UTIs, that could be a problem for them. Something to note there. And then vaginal infections tend to be a little bit more common, a little bit more difficult to treat, but it's one thing just to educate them on. And then patients who have kind of pre-existing kind of menstrual irregularities, they tend to be more likely to develop amenorrhea. And also these may be patients who have like things like prolactinomas, PCOS patients, especially kind of think about that sort of thing. So that could be one thing that develops there. And then the severe one, when you always worry about, especially if you see like a young lady coming into the ER to diagnose with a PE or a DVT, you always ask, are you on birth control? And then what else you ask them, what do they do? Do they smoke, right? Because again, two of those together definitely going to be a bad combination. I always recommend, hey, if you smoke, oral contraceptive is probably not a good option for you. There's other means we can go about to provide contraception, but if you're going to smoke and you're not going to stop, this is a bad combo here. And so you can find that the risk is going to be threefold higher while on low-dose oral contraceptives versus being on nothing at all. So the risk is always going to be elevated as long as you're on the drug. However, it's one of those things where you can do some things to kind of help yourself. So again, not smoking and things like that. And so it begins with the first month, that risk is increased, and it's going to be increased until you kind of come off the meds altogether. So that's one thing to note there. And so again, if you have a hypercoagulable state at baseline, so if you had something like factor V Leiden, or if you had any kind of coagulopathy at baseline, this is going to worsen that risk there. So again, that would be another one where I'd be hesitant to recommend oral contraceptives for them, right? Because again, the oral contraceptives is going to be very systemic acting. And again, when you take an oral contraceptive, what's the first organ it's going to interact with besides the GI tract? The liver, right? So that first pass effect there is going to be really important. So if you had someone who was not a good candidate for oral contraceptives, there are other means we can use to treat them, and we'll talk about those a little bit later. Okay, some patients may be more at risk for MIs, and this can be related back to, again, having that clotting propensity there. Obviously, going to be more at risk for like patients with already at risk for MIs anyway, so diabetics, hypertensive patients, things like that, and certainly smokers are going to be at the biggest risk there. Again, risk of stroke can be increased here as well. And then as far as from a GI standpoint, a lot of this again goes back to the oral nature of these meds. You can see things like cholestatic jaundice tends to be more seen kind of in the beginning, a couple of months of them taking it, and it will definitely resolve within a few weeks after a discontinuation of therapy. So one thing to know. Some patients may actually have worsened depression associated with this. It's hard to predict, again, who's going to actually have this. Some patients' mood may actually be helped by using estrogens and progestins, but it just depends. And then the risk of cancer is going to be there as well. So again, typically they have kind of a reduced risk of endometrial and ovarian cancer kind of overall, especially because of that progestin usually including there. And then they see that the lifetime risk of breast cancer tends to not be really affected. However, if they have a really high risk history, that would be one thing you want to consider and kind of have a conversation with them about. And they do see that cervical cancer risk is increased in women with HPV co-infection. And again, how many people have HPV? Quite a few, right? Nowadays, it's probably going to be going down pretty significantly. Now that Gardasil is much more of a thing. Really wasn't a thing when I was at that age. However, more and more patients are going to be having that vaccine. Hopefully, it'll kind of eliminate some cases of HPV. However, does Gardasil cover every single type of HPV? No. Now we cover like 9 variants, the more clinically important ones. However, we can't get all of them, unfortunately. Okay. So looking at the progestins, these are good things to kind of have an idea about some of the differences between the progestins. And so these are kind of some different activity you're going to see here. So we kind of the first generation ones. These were a lot of our old school orthotricyclines and kind of standard sort of oral contraceptives contain these sort of progestins. So things like norethindrone, norgestrel. These are going to be some of the main ones you're going to see in usually a lot of the generic varieties or ones that have been around for a while. Tend to have pretty good progestin effects here, but they tend to be a little bit more high on the androgenic side. Okay, this is one thing to note here. There's a second generation called levonorgestrel, which you'll see more often in like IUDs and implantable birth control. This is also when we think about like our Plan B, which is used for emergency contraception. You'll see levonorgestrel used there. You're going to find pretty high androgenic activity as well. So this one may not be good from a systemic standpoint, just due to the fact it's going to have more androgenic side effects like hirsutism and potentially worsen acne and things like that. Nowadays, we're starting to get away and using things that maybe have less androgenic activity like norgestimate, but the big one I see a lot of patients really responding well to is going to be drospirenone. Drospirenone is nice because it actually has some anti-androgen sort of effects here, and also some anti-mineralic corticoid effects. So if anything, you may actually lose a little bit of weight when patients start this, and you find this like in your Yaz and Yasmin and products like that. So drospirenone, I see a lot of patients responding pretty well to it for the most part. Okay, so again, contraindications you want to watch out for, so things like thrombophlebitis or any kind of history of like cerebrovascular disease, and then any sort of unknown cause for vaginal bleeding. You do not want to go and start oral contraceptives here. It may fix that oral contraceptive, or it may fix that bleeding, but what's the thing with unknown uterine bleeding you want to watch out for? Yeah, you got to make sure it's not something scary like cancer right before you start kind of monkeying around and giving these patients extra hormones. So again, always make sure you kind of have that diagnosed first. Certainly any estrogen-dependent tumors, I would not want to go ahead and administer to these patients. They have heart failure, because again, we mentioned what does it do to your fluid status? Yeah, typically edema is going to be an issue there. And then if it's an adolescent who's not undergone epiphyseal closure, I would not want to administer here either, because again, what does estrogen do to the growth plates? Going to close them up, right? So potentially you could run into like premature growth stunting potentially. Watch out if you have any hepatic enzyme inducers on board, so like rifampin. Where do we use rifampin at? Yep, TB is the most common place there. Or phenytoin, which we use for. Yeah, so be careful there, because if you use it, someone has a seizure disorder, don't want to necessarily be careful and make sure they are not having any enzyme inducers on board, because that will interact here. And again, that will drop your levels of estrogen and progestin, and it's going to increase your chance for having a pregnancy. Mentioning antibacterials, and obviously if they are pregnant, you probably don't want to start them on an oral contraceptive. Now, are there cases where someone happens to be on an oral contraceptive and being pregnant at the same time for a period? Sure, lots of people don't know they're pregnant for a while in some cases, but you would not want to start that for those patients. Does that make sense? Okay, so progestin-only contraception, we mentioned, is going to have a little bit higher risk for failure in some cases for patients, but you're going to find this is going to be suitable for those who cannot or should not receive estrogen-based products, right? It's going to be nearly as effective, but the margin for error is going to be a little bit higher here. You're also going to find there's going to be a higher incidence of abnormal bleeding. This tends to decrease with time as they go on, and then amenorrhea is going to be pretty common for these patients as well. And then you can see a delayed return to ovulation, right? So again, if you have someone who has a very kind of specified time frame for when they want to get pregnant, so say for instance, like, hey, I'm going to PA school, here's a 2-year period where I probably don't want to get pregnant, right? I can't speak for everyone, but I imagine if I was in pharmacy school, it's like for 4 years, I probably don't want to get anyone pregnant for this time frame. But you can say, hey, afterwards though, I'm good to go, I'd like to get pregnant. You may find that a progestin-only product is not going to be great for them, because you could have a delay. I don't know if I mentioned it last week or not, but I was talking to my cousins about birth control and things like that, and his wife had been on oral contraceptives all of her life, went off of them, and they were able to get pregnant pretty quick. However, after that first pregnancy, she went on the depot shot, which is just going to be medroxyprogesterone, progestin only. And when she came off of that, when they were ready to get pregnant again, it took them almost 2 years, right? Because of the fact that she just had that delayed return to ovulation. Not everyone's going to be like that. Some people may be only a few months. However, it can be pretty prolonged depending on what's going on. Okay. Okay, looking at postcoital contraceptives, these are like your Plan Bs, like your emergency contraception here, or your morning after pills as they may call them. So again, you may find that these are going to be, and again, depending on what the situation is, you just kind of mentioned here just for completeness sake. However, it can be estrogen only, it could be progestin only, or it could be a combination of the two. And in fact, there is a way to kind of take an oral contraceptive pack that the patient already has and utilize a bigger dose than what they would already normally take in a given day and use this for emergency contraception. More often than not, though, they're going to utilize something like a Plan B sort of product, which happens to be levonorgestrel by itself. And so again, this is something, do you need a prescription to get one of these? Actually do not need a prescription anymore. You can go to the pharmacy, and if they have it, they can fill this without a prescription because of the fact that what's kind of the time frame you want to use this if you need to utilize it. Yeah, like within 3 days, right? So obviously the sooner the better if you need to utilize this, but 3 days is kind of the thing here. So there is a kind of a time frame that's important. So the most common one, as I mentioned, is going to be levonorgestrel, which is Plan B. Typically, they're taking a pretty big dose here, and if you kind of compare the doses of progestins and that table I was showing you earlier, this is a lot bigger dose. So again, a very big dose of progestins, kind of starting like a new menses kind of immediately, kind of flooding the system a little bit there with progestin, and hopefully preventing that implantation from happening, right? So big thing they're going to see though is a lot of nausea, vomiting associated with this. So again, I would probably recommend if you were recommending this to a patient, I would recommend giving some Zofran as well, right? Because again, if they throw it up within an hour or so, guess what? They probably didn't get that full dose, right? So then they may need to retake it. And again, if they're already kind of worried about throwing up because they do it the first time, there's some anticipatory aspects there. So you got to be careful. So I would definitely recommend taking it with some sort of antiemetic. And again, within 72 hours is super important there. Okay.
Will the pharmacist tell them that they should either get like an over-the-counter, or can the pharmacist give them Zofran?
Yeah, we cannot give them Zofran. That's still a prescription-only based product. So I would probably recommend like maybe taking like some Benadryl or something beforehand just to try to help that out. But you know, not everyone's going to throw up, but you know, it's it's a high enough incidence where I would say, hey, if you do throw up, you probably need to take another dose if it's within an hour. Yeah, if it's after that, it's already past the pylorus of the stomach. You're probably fine at that point. Okay. So some other beneficial effects you can see here. So certainly there's reduced risk for certain things. So things like ovarian cysts, endometrial cancer, ectopic pregnancy is good. A lot of these products will have iron built into them, depending if your patient happens to be anemic. But why do you think this could help with iron deficiency? Yeah, potentially if they're bleeding less, or potentially there's some of these products where you can actually only have 4 periods a year, or maybe just 1 period a year. And so if you're bleeding less, you're holding on to more iron, that can hopefully help with your hemoglobin there. Some patients actually have lessened risk of rheumatoid arthritis. I don't know the mechanism for that, but apparently it seems to be a decreased risk there. And certainly endometriosis is helped out with this. Certain patients will have better improved acne. Hirsutism may be improved depending on the type of progestin you're giving them. So again, if I give them a really highly androgenic progestin like levonorgestrel, this may be worsened, but in some patients may be helped, right? Because again, there's a delicate balance between androgens and estrogens in the body. Because remember, androgens get turned into estrogen. Remember that what enzyme does that? Aromatase, right? So again, if I have more estrogen around, I'm going to have less testosterone being produced because I have less LH and FSH. That can actually help with some hyperandrogenic sort of states. If that makes sense. So oral contraception, typically I recommend going with a combination product to begin with, and typically you want to use the lowest effective estrogen content, so usually between 30 and 50 micrograms, not a really big dose we're using here. Or again, depending on which estrogen product, the dose can be kind of misleading because again, we're giving super therapeutic amounts of estrogen, but this tends to be a little bit more potent than you would see with some of the products you may use in like a Premarin or something like that, right? Make sure you're kind of looking at you know, a long enough time frame to see kind of how they were responding to it, because again, you know, you need to monitor for several cycles before you can kind of say, well, this is good for you or it isn't good for you, depending on kind of what side effects they're having, and kind of wanted to give them a chance to kind of get back to kind of their new normal while they're on the contraceptive, as far as like, you know, withdrawal bleeding and things like that. So usually I'd recommend like a 3-month supply just to kind of get them started on it and see how they're doing, and then you can kind of readjust it after at that point. And again, depending on which insurance they have and things like that, they may find that different products are covered. So even though you may have like 2 or 3 that you really recommend on a routine basis, depending on the insurance, you may need to kind of find one that more fits better for what the patient can afford and whatnot. So typically when you're starting a new oral contraceptive, and again, there's no hard and fast rules here, but these are kind of the general things that they recommend. Again, when I found out a lot of this stuff, I was just like, this seems like witchcraft, to be honest, but it's all just physiology, So anyway, so normally they say, okay, start the first Sunday after the onset of menses. And so again, why do we recommend starting on a Sunday? It's easier to remember. So, okay, but you could do that, like say, take every Wednesday. Huh? It doesn't ruin your weekend. Yeah. So it actually helps to prevent withdrawal bleeding on the weekend. So hopefully if you start the withdrawal bleeding on, say, on that Sunday or Monday, by the time the weekend hits, Friday, Saturday, Sunday, like you've kind of already gone through the majority of that withdrawal bleeding. So it kind of helps to leave your weekends somewhat period free. So again, if you have someone who like, I work every single weekend, I don't really care, it doesn't have to be a Sunday. But Sundays is kind of historically what they've always recommended. Typically post-pregnancy, they'll go ahead and recommend 3 to 4 weeks or so after pregnancy, you can go ahead and start on an oral contraceptive, but be aware if they're breastfeeding, that may be inhibited there. So they may need to either use something that's not going to be orally used, something like an intrauterine device, or if they're going to, if they're using formula anyway, it doesn't really matter at that point. And if they had an abortion, you could do the first Sunday thereafter, because again, that'll get them back on like a normal cycle. Okay. Now there's going to be some the question of whether or not you need to use an alternative form of birth control. So again, recommending either like using a condom or things like that. Some people say, hey, with the first cycle of oral contraceptives, just use a backup. That's not necessarily based on any kind of good clinical evidence. Theoretically, if you have the estrogen and progestin on board, you're not going to be likely to get pregnant. However, I would probably rather be on the safe side of things and say, hey, for the first cycle, just go ahead and use a backup just in case. Now, if they miss pills, and we'll talk about missed pills in a few seconds here, but you need to be careful. The lower dose estrogens that you're using, or if you're using progestin only, missed pills tend to be more of a big deal. So we'll talk about how we can deal with that in a second here. If you're having severe diarrhea, how do you think that may affect your oral contraceptives? As you mentioned, the estrogens are undergoing that enterohepatic recirculation, so I'm having very severe diarrhea. There may be a case where I'm not having a chance to reabsorb that stuff so well, and so that could be a case where you recommend maybe using an alternative. And then antibiotics, as I mentioned, again, I'd prefer to be on the safe side, so I say, hey, just go ahead and use a backup method while you're on the actual antibiotics. So if you miss a pill, say for instance, I missed today, I forgot to take my oral contraceptive today. I usually don't take mine until the afternoon, but to say, for instance, I just missed it. Go ahead and take it as soon as you remember, right? Or recommend that they take it as soon as they think about it, so that way they kind of get back on track, right? And again, you'd like for them to be consistent, maybe take it at the same time every day. It's not mission critical that they do that. It's more so for progestins. You kind of want to make sure, hey, take it at the same time every single day, because again, that also helps with the repetition. It helps with them remembering to take it. But if it's a few hours, not a big deal, right? If they miss 2 pills, they missed yesterday and they missed today, have them take 2 pills for 2 days. That'll get them back on track, and there is low risk for them having an unexpected pregnancy. Okay, so miss 2 pills, take 2 pills for 2 days, back on track. They miss 3 or more, margin for error is too high at that point. I say go ahead and just DC the rest of the pack and start on a new Sunday. Okay, so again, even if there's still plenty of drug left in that pack, say hey, just go ahead and forget about it, go ahead and toss it, we'll get a new refill, and then go ahead and restart on that Sunday. Okay. That's typically what we recommend for most patients. That gives you kind of enough of a safety margin where you're not worried about them potentially getting pregnant. But for that 3-day mark, then it's a little too iffy at that point. So if they missed a period, so they have that failure of withdrawal bleeding, and they say, hey, I took the pills like I should. Here's the pack I can show you that I take them every single day. I probably would not pregnancy test them immediately. I'd probably go ahead and wait till after that first missed period. I would go ahead and say, well, let's go ahead and check them maybe at the next time. If you're trying to reschedule the menstrual cycle, you can do this, and basically what you can do is actually just continue active drug until that period where you want to go ahead and actually have the period itself. So for instance, I would say if they had a big event coming up or they were going to go on vacation or something like that, skip the placebo pills and just start a new pack and continue active drug until they're at a period where at a point where they can have a period, and then they would just go ahead and stop at that point, right? And then they can kind of get back on a normal cycle or normal schedule at that point. Does that kind of make sense? So again, as long as you're on an active drug, you don't have to worry about having menses at that point, because again, we're still shutting down the whole system at that point. Now again, is there any need to have a rest period? Not really. You can continue taking this stuff continuously. It's no problem there. But if you want to have a desired pregnancy, at that point you want to kind of wait kind of say, 3 regular cycles, you should be back to ovulating normally. Certainly, the patient can get pregnant before then, but that's kind of what they say is like, give it 3 times before you start to get kind of worried about things not occurring like they should be, right? At that point, you should be kind of ovulating as normal by that point. Okay. Now, if there's any kind of breakthrough bleeding that's occurring here, typically this can resolve within the first 3 months. Your body's kind of getting used to it over time. However, if it's still present after that period of time, you can kind of get an idea for what the issue is based on where the bleeding is occurring at throughout the month. So, for instance, if it's kind of occurring early on during the month, say the first 1 to 14 days, it's usually related back to an estrogen deficiency. So I can maybe switch to a product where they're getting more estrogen early on in the month, and that typically will help kind of resolve some of that bleeding associated with that. However, if they're bleeding later on, say that 3rd week, typically is related back to a progestin deficiency. So I may switch them to a product with more progestin activity or with just a higher dose of that progestin there. So again, based on when the bleeding is occurring, kind of get a feel for what's going on there. And again, because we're always shooting for the lowest dose possible, but the lower the doses are going to be, the more likely are to see some bleeding side effects. Okay. So some miscellaneous products you may run into. We'll have things like medroxyprogesterone acetate or Depo-Provera. How is this one given? Yeah, intramuscularly, right? So anytime you see Depo something, usually it's going to be a product that's meant to be injected intramuscularly, and it lasts for a while, right? So you might see like, I'm trying to think of any other Depo ones. Like there's like Depo testosterone-based products. There's some that are corticosteroid-based products, but basically they're usually like in some sort of oily sort of base that slowly releases from the muscle. So it's nice because if you had someone who maybe doesn't want to think about taking a pill every single day, or maybe someone who is maybe participating in high-risk activities, or you're worried about them getting pregnant, but they're not going to be compliant with their medications, this is another good one to use as well. So you can use 150 milligrams injected intramuscularly, and that lasts them for 3 months. The nice thing as well, the actual duration of effect lasts longer than that 3 months, and so even if they were, say, lost to follow-up for a few weeks, it's okay. They're probably still not going to get pregnant based on the progestin they got there. But you may find pretty irregular menstrual bleeding patterns associated with this. That is one thing to note with this one. More likely to have those bleeding issues. We also have some intrauterine devices here. So here's one variety. Most of these are going to be progestin only. So this is levonorgestrel or Mirena. And the benefit of these, they last a very long time. So some of them will last 3 years, some will last 5 years. This one in particular will last 5 years. And so basically the OB-GYN or whoever would go ahead and administer this in the office. And basically they would place this right here in the uterus and allow it to kind of slowly release that progestin locally. And the nice thing here is you mitigate a lot of those systemic side effects. And again, it doesn't do anything to inhibit ovulation because all this progestin really just stays right here. All it does is change that local environment to make it very unlikely for the egg to actually kind of travel down and be in a point where it can actually meet up with the sperm and implant, which is kind of the main thing you're trying to shoot for here. And basically it has these little strings on the end here, which whenever they're ready to come out, so say for instance they wanted to get pregnant before that 5-year period, then you just go ahead and pull that thing out and then you're good to go. Typically. And, our OB-GYN said, hey, I've seen some patients as soon as they pull one of these out, they get pregnant the very next day. So again, it's a very kind of local effect, very sort of fast acting and fast offset. So that can be very beneficial for your patients looking to get pregnant. Some other ones, you have things like NuvaRings, which is going to be a combination of ethinyl estradiol and then etonogestrel, which is just another type of progestin. This one can be placed intravaginally, and this can be done by the patient themselves. And this would be one that would be 3 weeks in, 1 week out. That way, you would still get a normal sort of period that could occur there. So that can be very beneficial from a contraceptive use. The Nuva Bling. This is one for patients who have the really good insurance, right? Just kidding. That looks like it would be very uncomfortable, so I would not recommend this product to anyone. And then there's some that can actually be implantable. So again, instead of having like an injectable product you use every 3 months or so, you can have one that just releases progestin very slowly. So like something like Implanon can be put in the underarm, and it just stays there and changed every 3 years or so, right? So again, different options for different patients. It all depends on kind of what is going to be working best for them, their lifestyle. Here's one that's going to be a copper based intrauterine device. Is called Paragard, and so basically by slowly releasing copper ions kind of locally, again it can have good effects to kind of impair sperm transport, impairs that fertilization and implantation process there. So again, using kind of heavy metals in a very local sort of sense in order to kind of decrease the ability to get pregnant. So very kind of cool from that standpoint. This one can actually be used for emergency contraception, which I just learned not too recently. So some patients will will utilize that. Basically, if they had a case where they think they need an emergency contraceptive, they could have this put in, and basically that will prevent that implantation phase from actually occurring in the or ever occurring there. And this one lasts for about 10 years or so. So again, it can be stuck there for a good long time frame. Okay, so any questions on the oral contraceptives? Let's go ahead and take a break. We'll come back and then we'll finish up this section and then move on to the next one. All right, so we're going to finish up by talking about a few antagonists, agonists, sort of mixed drugs here. We've talked about these a little bit in the chemo section earlier on. We'll kind of talk about them here a little bit again. So again, normally when you have something like estrogen, progestin come along, they should be able to shut down this whole negative feedback loop here. But there's other ways we can inhibit this as well. So we're going to talk about like a few different things. We mentioned this in the androgen section a little bit, like GnRH agonists. Right, so remember we talked about like leuprolide and things like that can actually, by overstimulating those GnRH receptors, that can basically say, hey, okay, let's shut down this whole system again, which can be good in higher doses if you need to maybe inhibit production of LH and FSH, or it could be used in smaller doses to actually stimulate, and for kids that maybe have like a tumor or something like that, where they need, or their hypogonadism, they need a little bit of extra GnRH there to stimulate that. So it can kind of have either effect. But we'll also look at things like aromatase inhibitors, which are going to be really important. This is going to be used more so in like patients with like treatment-resistant breast cancer, where you really need to shut down estrogen production. So we'll look at a few of those here in just a minute. But one of the big ones we use nowadays is called selective estrogen receptor modulators. Remember we talked about like tamoxifen or raloxifene back in terms of breast cancer. These are nice because they're mixed agonists, antagonists. So they can act as an antagonist in the breast tissue, but maybe potentially act as agonists in other places, right? So tamoxifen was really the first one, and basically it was able to be an agonist in the bone and the endometrium, but an antagonist in breast tissue, right? So what was the benefit here for like the bone aspects? Yeah, so potentially it could be good for osteoporosis. But it would antagonize the breast tissue there. Maybe not good for cervical cancer potentially, because it's stimulating the endometrium there, so that would be one thing to consider. But again, it just depends on what tissue you're dealing with, because they have different types of kind of different flavors of estrogen receptors essentially that the drug can interact with. And so we'd use this a lot for like breast cancer prevention and like really high risk history patients, or if they needed palliative care for like breast cancer. Now, one of the big side effects you're going to see with these, anytime you're antagonizing estrogen effects, are going to be what? Kind of like you're giving a menopause to some degree, right? So hot flashes are going to be a big side effect here. Vomiting associated with this in quite a few patients. And so tamoxifen is still used occasionally. Usually it's kind of a backup means if other drugs have failed. But we use certainly a lot of raloxifene, which I'll mention here in just a second. The other big thing, though, is it's nice because you can see some prevention of loss of lumbar spine bone density, so good for patients at risk for osteoporosis. However, though, this one's not great because mainly of that increased risk for endometrial cancer, especially those who still have an intact uterus. Usually need some sort of progestin on board to help prevent that from occurring. And then also there's some risk for thromboembolism. So it's a good drug, but and again, it's one of the first ones we had in this classification, but not used quite as much as a first-line agent anymore. The other one used quite frequently is raloxifene, and so this one's good because it has good estrogenic effects on the lipids and bone where you want it. However, it doesn't really stimulate the endometrium or the breast tissue. So again, this is used a lot of times more first line than you'd see like tamoxifen used occasionally. So again, good for osteoporosis, also good for high-risk breast cancer patients if you did not want to use a typical sort of estrogen for someone who had a high risk. Some other ones like clomiphene. This one's actually an older partial agonist, and this actually helps to kind of disrupt that negative feedback loop to some degree. And we actually use Clomid as a ovulation stimulating agent. So if you had someone who's having difficulty getting pregnant for a while, you can actually utilize Clomid to try to kind of get them, kind of jumpstart their ovulatory cycle again and try to get them to a point where they can get pregnant. So you'll see that when used with some regularity in like reproductive endocrinology clinics and whatnot. Some other ones we can have here, these are going to be pure estrogen antagonists, and again, the side effects are going to be pretty severe from like a sort of inducing menopause sort of standpoint. We have things like danazol. This one has really good effects to suppress ovarian function, mainly because it's inhibiting LH and FSH. But certainly you can use it for things like really more like treatment refractory endometriosis, and actually in some cases we actually use it for some allergic or hematologic disorders. So things like ITP. Anyone know what ITP stands for? It's idiopathic thrombocytopenic purpura, right? So it can have for some patients, hemophilia, things like that. But obviously, you're going to have a lot of side effects associated with it because it's mainly going to be much more androgenic in a lot of cases. So things like deepening of the voice and hair growth and things like that. So not a great drug, but useful if you need it, if nothing else was really working in those cases. And then we have some aromatase inhibitors, and again, big side effects here are going to be more on the androgenic sort of standpoint, and then also just due to a lack of estrogen, because we're basically shutting down the ability to produce new estrogen by inhibiting that aromatase enzyme. So you have things like anastrozole, letrozole, exemestane. This is going to be even more so pretty severe acting because it's going to be irreversible inhibitor. So until you produce new aromatase, it's not going to be able to convert that over, and so again, a lot of androgenic side effects associated with that one. And again, you're going to find the most risk for fractures here, which makes sense because as opposed to like a SERM, like a tamoxifen, you at least get some estrogen activity out of that, especially on the bone. Here, you're kind of inhibiting all estrogen production, and so you're going to find that has pretty negative effects on the bone. So osteoporosis would be a big risk there. Yes, ma'am.
So for the estrogen antagonists, like, since they have like, they're used for stuff like endometriosis and whatnot. Well, you wouldn't want to give that to someone who's interested in having children, right?
Well, as long as the drug is not in the system, then it really shouldn't be inhibiting things, you know. So it's not like one of those really long-acting sort of drugs that would be a concern, you know, well after the half-life of the, you know, after the drug's out of the system, essentially. Yeah, basically. Certainly not when it's around. Yeah, we don't want to do while they're on it potentially. Okay, so that's it for the women's health sort of section. Any questions on this? Yes, sir.
Are there any like long-term side effects to oral contraception?
Like we mentioned, you know, certain cancer risk could be modified by this. You know, they say like, you know, lifetime breast cancer risk tends to not be changed that much. But again, kind of goes back to that and looking to see what kind of long-term studies are out there. But those are the main concerns there. But again, a lot of the effects, as soon as you're off the drug, things like thromboembolic risk and things like that, as soon as you're off the drug, then you kind of goes back down to baseline, which is kind of the benefit there. All right, I'm gonna cut this off.